Today we're going to discuss a case of a gentleman who is 83 years old who presented with back pain and fatigue. His laboratory workup showed anemia with a hemoglobin of 7.9, a monoclonal protein in his blood of 3.8 grams per deciliter, an LDH of 290, slightly elevated, normal albumin, elevated beta-2 microglobulin, creatinine of 1.5 milligrams per deciliter, and given the suspicion of myeloma, a free light chain kappa of 134 milligrams per deciliter. This gentleman had a past medical history of a cardiac stent for coronary artery disease 3 years ago, a high BMI, and a history of hypertension. Subsequent workup included a bone marrow which showed good cellularity but 60% involvement with bone marrow plasma cells, normal cytogenetics, and standard risk FISH. An MRI of his spine showed multiple focal lesions and moderate diffuse changes throughout the vertebrae and proximal femurs. He had an ECOG performance status of 2. Overall, we would summarize this case as a stage 3A Dury-Salmon IgG multiple myeloma requiring treatment with symptomatic anemia and bone lesions. The patient was started on a combination of Revlimid, dexamethasone, and daratumumab. The first question with this elderly gentleman is the question of transplant eligibility. Most places in the United States will accept patients into their early 70s, sometimes older, if they have good performance status and are in excellent health with no significant comorbidities. Generally speaking, however, in many countries around the world, the upper limit for transplantation is 65 or 70. This gentleman, age 83, is probably for almost all transplant centers slightly above the age at which one would consider an aggressive and somewhat debilitating treatment such as autologous blood stem cell transplant. So age alone in this case would be one of the criteria that would make him transplant ineligible. Other issues would include his coronary artery disease, his hypertension, and the fact that he's overweight, all of which would lean against moving forward with more aggressive high-dose melphalan and autologous stem cell transplant. As you know, the average age of onset of myeloma is in the mid-60s, sometimes early 70s, where we peak out in terms of incidence, which increases with age. It is hard to know exactly what percentage of patients are eligible for transplant today, as the bar is always moving, but generally speaking, less than 50% of patients who present with multiple myeloma would be considered eligible for autologous stem cell transplant. In a younger patient who was transplant eligible, there are many options for upfront therapy today. In the United States, however, it is generally preferred to give a triplet combination of drugs, the backbone being the use of dexamethasone, a proteasome inhibitor, and an immune modulator. Generally speaking, in the United States today, that translates into the use of bortezomib or Velcade, Revlimid or lenalidomide, and dexamethasone, which is the most commonly used regimen. Generally speaking, bortezomib is given subcutaneously once a week to prevent or diminish the risk of neuropathy. An alternative which is emerging and is gradually gaining some foothold is the use of carfilzomib in replacement of bortezomib. Carfilzomib is a more potent proteasome inhibitor. It's given intravenously, however, on a slightly less convenient schedule, twice weekly, but increasingly it's being used weekly as well, but is an intravenous delivery. This is generally being used for higher risk and younger patients without a history of cardiac disease. In patients who have geographic challenges, or perhaps in the more elderly patient as well as the transplant eligible, the use of ixazomib, although not approved yet by the FDA in this situation, could be considered. Another option in the treatment of both the younger and older patient in situations where it is difficult to access an immune modulator because of insurance, the ability to pay, or tolerance, or perhaps in patients who have developed some renal failure, is to use Cytoxan. The combination of Cytoxan, bortezomib, dexamethasone is a very effective early treatment option, but most people would try and switch to an immune modulating drug such as Revlimid when that became available.